Stanford University.
So it's my real honor to introduce my close friend, Dr. Todd Rosengart. Dr. Rosengart did his undergraduate medical school with honors at Northwestern University and did his general surgery training back when we had general surgery training as part of our pathway. Did this at NYU, and then he went up to Cornell in New York City to do his cardiothoracic surgery training. And during that time, he became involved with a very famous research scientist, Ron Crystal, and the two of them actually pioneered a lot of the work in cardiac gene therapy and did the world's first, or the US's first trial looking at VEGF gene therapy in the heart in a clinical trial for myocardial ischemia. He's gone on to pioneer several new things in cardiac regenerative therapies. And not only has he continued to be active in the surgical arena, but has maintained a very active clinical practice in valve surgery and coronary surgery, despite being a chair at two programs. Dr. Rosengart became the chair of the Department of Surgery at Stony Brook, and then most recently became the DeBakey Chair of Surgery in Houston at the Baylor College of Medicine. And among some of the people that he has the privilege of working with on a daily basis include names, for those of you in cardiac surgery familiar with these names, people like Denton Cooley and Bud Frazier and Joe Caselli and a variety of other luminaries who have published really a lot of the history and the development of cardiac surgery. These are the people that Dr. Rosengart has the opportunity to work with on a daily basis now. So Dr. Rosengart also has had a very viable and continuously funded research laboratory funded from the NIH with a tremendous publication track record studying gene therapy and cellular reprogramming and other regenerative therapies, and is here today at our invitation to educate us on novel reprogramming technologies and trying to do the unthinkable. Todd?
Thanks, Joe. And while we're getting us started, first of all, my thanks to all, Joe and Joe, a great old friend and a great new friend, and it truly is a pleasure. I don't need to, of course, tell anyone here how significant and memorable Stanford is, but by coincidence, I will mention that one of my other side jobs is editing one of the cardiac surgery journals, Seminars on Thoracic and Cardiovascular, and we recently ran a special issue on great institutions in cardiothoracic surgery, and the very first article was Stanford, 100 years of history here that Joe Wu, surgeon, contributed. And of course, truly a remarkable place that we all from the outside, you lose perspective on who you are and what you're doing when you're at a place for very long. But of course, needless to say, Stanford is a very, very special place in all of our consideration. So I'm going to talk to you today a bit of science, but perhaps equally importantly, especially for the younger residents and PhDs and scientists in the room, the concept of thinking the unthinkable. And really most of what I'm going to talk about my 30-year journey in terms of cardiovascular medicine and science and discovery is really unthinkable. And as we've heard this morning, most of what we're talking about today, if you talk to some of the older people in the room, would really be close to heresy to suggest, for example, that you could grow new blood vessels or let alone take a fibroblast and turn it into a cardiomyocyte. You would literally have to be committed. You would be banned from future science and the like. But again, the theme of what I'm hopefully will convey, again, especially to the younger scientists, is if the data are there and you believe in what you're doing, think the unthinkable and go for it. And again, I think a lot of what has been so wonderful and I'm so grateful about in my career is having had the opportunity to do that. So the theme of what I'd like to talk about today is the treatment of heart failure. As many of you know, this remains a very, very significant problem in American medicine. 5 million Americans have heart failure. Current medical and surgical therapies are still associated with very high mortality, limited applicability, as we'll talk about. 300,000 patients or individuals annually require transplant or VADs, but less than 5,000 transplants or VADs are performed annually. Of course, Stanford is truly the epicenter and the home of certainly heart transplants, and of course the VAD program here is second to none. So in many ways, there are probably at least 1 million individuals in the United States annually who are candidates for something other than having their heart cut out, heresy to say it here, but it's true, or having a machine put in their chest to take over heart function. Wouldn't it be nice if there was a biologic way of repairing someone's own heart so we didn't have to undergo such extreme surgical procedures? Again, hard to believe a surgeon would be saying those things, but it's true. And again, as I mentioned, even under the best of circumstances, Mark Slaughter's data from New England Journal in 2009, there's still a 20 or 30% 2 or 3 year mortality associated with even the best of mechanical circulatory support devices. And then again, of course, having to do heart transplant is not a trivial undertaking. Recent story, as we're going to talk about, we're getting ready to begin a angiogenic gene therapy trial. And I was sitting on the medical review board over Texas Heart just a few months ago. There's a patient with end-stage angina and literally had failed all medical therapy, no bypass, no angioplasty operation. And they were literally talking about this patient and said, we're going to do a heart transplant. There's nothing left to offer this patient. Normal ejection fraction, just advanced angina. And I sheepishly raised my hands in the room with all these heart transplant surgeons. And I said, before you cut this patient's heart out, maybe we can inject some genes into the patient's heart and let him grow his own bypasses. And by the end of the meeting, I had about 7 cardiologists lined up wanting to enroll patients in the trial, clearly underlying the fact that there's a tremendous need for what needs to come next other than such aggressive surgical therapies. So what I'm going to talk about this morning, and we'll get to this towards the end, is something very different, and this will be a little heretical than what is customarily thought of for cell therapy for treating advanced heart disease. Most of the time, and important that we're clear on this definition, and depicted on the top right is obviously a cross-section of this experimental animal of an infarction, the area of a thin tissue. Over here, most of the time when we're talking about stem cell therapy, and again, I'm probably going to offend a number of people in this room right now, what we're really talking about is depicted over here. This is, again, an experimental model, and we're taking a large area of infarction, and we're injecting a bunch of exogenous cells, stem cells, mesenchymal stem cells, embryonic stem cells, iPS cells even, taboo area to be critical of. And what we're doing is something that ends up looking like this. And if you talk to most stem cell scientists, they will say, yeah, that's what it looks like. So you have this giant area, sea of fibrosis, and you have islands of stem cells working there. And then these scientists say, well, this is great. This improves heart function dramatically. And I and others will argue, and the clinical trials will support, it really does not make much sense that these islands of stem cells sitting in a sea of fibrosis are really impacting global heart function. So we'll get back to that. We're going to talk about this afternoon is in situ cellular reprogramming. This sort of crazy idea that you can actually take some of these fibroblasts in the area of myocardial infarction, actually convert them by direct reprogramming back into a cardiomyocyte phenotype and thereby improve function. But let me put that aside for a minute and go back about 30 years. It's hard for me personally to believe that I'm telling a story that's 30 years old, but it does happen to all of us, and I guess I'm there, and talk about the problem of advanced coronary artery disease. So again, as with heart failure, still a very significant problem despite the fact that we do over 1 million coronary stents, almost 500,000 coronary bypass procedures annually. But the secret, truth be told, is that about in half the cases, we don't completely revascularize or provide blood flow to the entire myocardium that's at risk because of ischemia or poor blood flow because of coronary disease. And in fact, through a number of large studies that have just been done in the last few years, Syntax, Freedom, among others, we now know, and we didn't know this up until about 5 or 10 years ago, that if you don't completely revascularize the myocardium, the mortality risk is about double compared to patients that are normal or completely revascularized. So again, a tremendous opportunity for something other than bypass or angioplasty to improve things. So we are going to talk about having the heart grow its own bypasses, biologic bypass or angiogenesis, and that's going to take care of everything. So let me go back 30 years. I was a resident working down at the NIH. My mentor, Wayne Eisen, was the chair of cardiac surgery at Cornell, said I didn't know what to study or what to do research on. He showed me 2 angiograms, one of a patient who had totally occluded a coronary artery, the other had grown what appeared to be collaterals. And he said, go and figure out how to grow those collaterals. So I saluted Dr. Eisen and I marched off to the NIH, and I said, I'll come back when I have it figured out. Of course, that did not happen. And back in the 1980s, the only thing we knew about any of this is truth, was that work by Tom Masiak and others who were just beginning, this is true, to learn how to grow endothelial cells in culture. This is 1980s, that's when this all started. And what Tom Masiak realized and showed in this paper in Science in 1982 is that if you withdrew a culture medium support protein, called at the time heparin-binding growth factor 1, or acidic FGF today, you grew these structures in vitro in cell culture that sort of looked like capillaries. That was it. That was the entire initial field of angiogenesis, these funny things in cell culture that look like capillaries. We were talking this morning with Dr. Nan, and we were saying that, well, how do you do these things? And you need to have the proper combination of growth factors. It's got to be in the right sequence. And in reality, if we ever tried to grow a blood vessel and come together with all of the different structures and molecules and cytokines and integrins and the like to make it all happen, we all would have quit a long time ago. But being dumb surgeons, we didn't know what we didn't know, and we just said, well, we can take angiogens such as FGF or in our area of interest, VEGF, and by some very fortuitous pathway, if you administer those exogenous angiogens, the entire angiogenic cascade will get stimulated, and that's exactly what happened. We became interested in vascular endothelial growth factor for a number of reasons, none less than it was a very potent angiogenic mediator, as I think everyone knows. It comes in 3 different isoforms, 121, 165, and 189. And essentially all of the work that was done involved one of those isoforms. We'll get back to that in a minute. As Joe Wu mentioned, I had been doing my work in angiogenic therapy. Collaborations and relationships, which you all here at Stanford are so fortunate to have, are critical, I think, to a scientific success. And I was fortunate to begin a collaboration at Cornell with Ron Crystal, who, as Joe mentioned, had been sort of the one of the early innovators and pioneers of gene therapy. And sort of like Reese's peanut butter cups, when you have the right combination of 2 things that have nothing to do with each other. My interest in angiogenesis coincided with Ron's interest in gene therapy. And I said, I've got this vascular endothelial growth factor, and I don't know what to do with it. And Ron said, I've got this adenovirus vector, and I don't know what to do with that. Well, so why don't we put them together? And we didn't end up with Reese's peanut butter cup, but we ended up with a nice collaborative research. So adenovirus, and despite speculation to the otherwise, is tremendously effective at delivering a fairly large packages of cDNA to induce transgene upregulation. Again, in our case, we're interested in VEGF. Is in particular very efficient at getting into cardiomyocytes, ideal for cardiac gene therapy applications. And importantly, and this is something that is misnomer or misunderstood about adenovirus, is it is a short-term expression vector, it lasts about 3 to 7 days. It remains epichromosomal in location, thereby preventing mutagenesis. And it downregulates not necessarily through inflammation, but probably by means that we don't completely understand. So again, very simply, I think everyone knows that the concept is really just regional pharmacotherapy. We repackage adenovirus with the cDNA, in this case for VEGF-121. We deliver it to the myocardium in order to turn on local cardiomyocyte induction of VEGF. And the concept is the gene therapy as we envision it was just a local drug delivery therapy, no more, no less, in order to deliver VEGF angiogen in order to cause new blood vessel to growth to revascularize scar myocardium that could not be treated by standard therapies. Well, back when we started, no one knew whether this would work. We went to a small animal model with VEGF-121, and as can seen on the right, we were able to induce profound angiogenic effect in a rat retroperitoneal fat pad. We found very early on that this was just pharmacokinetics. You give more VEGF or adenovirus, you get more of an effect. This is a standard pharmacokinetic therapy. I mention this because people forgot that this was just a drug, and they thought it had magical properties, and what ended up happening were applications that were inappropriate, and unfortunately it caused the entire field to crash and ended up setting the program back for about 10 or 15 years because people forgot these basics. Again, importantly, adenovirus works very, very well because it ended up that we just needed 10 days or so of VEGF transgene expression to have an effect. Conversely, if you used a chronic expression vector like adeno-associated virus, as shown in this paper by Lee, you ended up with hemangiomas, more transgene, more VEGF, deleterious effects, limited expression, and apparently, and as we later showed, solid efficacy. Of all the slides that and data that we published, the one that we produced, the one that we actually never even published is this slide right here. Probably more important than any work that we did. Probably cost the gene therapy industry hundreds of millions of dollars in false starts and lack of success, including companies presumably as bright as Genentech. And it is all that is depicted right here. So this is a very, very simple study. Anyone's child or grandchild in this room could probably do this study. And very early on in gene therapy days, we asked a simple question. What's the best way to deliver adenovirus so you get the transgene into the heart and get an effect? Should we inject it intravenously? Should we inject it in the coronaries? Or should we inject it directly in the myocardium? Simple study. Here's the results, and very clear to see. You have about a 1 or 2 log-fold increase in local myocardial expression. We use a beta-galactosidase marker gene if we went with intramyocardial delivery versus intracoronary delivery or intravascular delivery. Much more efficacious to go with direct intramyocardial delivery. We'll come back to that point in a few minutes. So we had our vector, adenovirus, short-term expression. That's all you needed. We didn't need to form hemangiomas. We had our transgene VEGF. We had shown in vitro and in small animal models was effective. Went to a large animal study, and this was sort of our eureka moment back in the mid-1990s. We took pigs, standard model. We put a circumflex amyloid constrictor around it, tied off the coronary artery, just as if you were having a heart attack. We treated the animals either with a null virus without VEGF or a virus with VEGF-121. And as exactly as we saw in human angiograms, we saw that we were able to grow a plexus of collaterals and literally reconstitute the circumflex coronary artery just as if as a surgeon I was doing a bypass operation. On the basis of this large animal data, we went to FDA in the early 1990s. We said we want to treat patients with end-stage coronary disease. We're just going to take this syringe, inject this solution into the area of infarction, grow new blood vessels, and the FDA said, you have to be kidding. That's the craziest thing we've ever heard of. We're not going to let you do it. And I don't care what kind of data you have. This is very bizarre, and you all should leave. And we really were up against a complete dead stop. All we wanted to do is take a tuberculin syringe, inject 1/10 of a cc of this VEGF solution into the heart, and we really didn't know what to do. So for those of you who have been around for a while, around this time in the mid-1990s, there was a technique called TMR, transmyocardial laser revascularization. And some crazy physicians or surgeons had the idea that if you took a laser beam and drilled a series of holes in the myocardium, you could reproduce a reptile heart, and the heart would perfuse itself directly from the chamber. Well, that, for some bizarre reason, had already gotten FDA approval, but the key point of the story was that we happened to have a video from the local Channel 2 News in New York of Craig Smith, a well-known surgeon, using the TMR laser beam to drill holes in the heart with this FDA-approved trial. But more interesting, the local Channel 2 reporter thought that it would be dramatic if he took the same laser beam that they were drilling holes in patients' hearts and took a 2x4 and took the laser and drilled holes through the 2x4. So we're at lunch break at the FDA, and really we're about ready to go home. And I said, Ron, Ron Crystal, my partner, maybe we should show the videotape of the 2x4. So that's a little funky, I don't know. And I said, let's give it a shot. So we put the videotape in. That was back in the days when it was still videotape. FDA panel, 20 people in the room, turned on the video, laser goes on the video, 2x4, smoke, flames, fire, everything. And we said, you guys just approved this last year. All we want to do is inject a solution in the heart. We got approval, and we were off to our clinical trial. Great science at work, absolutely true story. So the first trial was done in December of '97 at Cornell, as Joe mentioned. First time anyone, at least in the United States, had ever injected a virus into the heart. A little bit scary. We found a lawyer from Westchester to be our first subject, and we went on and did a series of patients, literally just injecting a grid of sort of Goldilocks, a Little Red Riding Hood with breadcrumbs in order to inject. They really did not know much of what we were doing. Our most famous patient was a columnist for Time magazine named Lance Morrow. I'll get back to that in a second. But after our phase 1 data, we had encouraging preliminary data. Our patients seemed to be feeling better. There was a lot of controversy that this might be a placebo effect, but we continued on, and this went on to a phase 2 study in Canada. We were not involved, and this basically looked at an FDA approval endpoint, which is time to 1 millimeter ST depression. And what was shown here with a very small n, 26 patients, looking out to 26 weeks after therapy, patients either getting the adenovirus with VEGF or a medical control group, statistically significant improvement in evidence of EKG changes, so not just angina, with this very, very small group. So pretty encouraging. Looked pretty good. And in fact, in that study, there was one patient who died for unrelated reasons. They were able to get an autopsy. This is a alkaline phosphatase stain that's brown for blood vessel. This is an untreated myocardium. You can see a couple of blood vessels. This is treated myocardium, pretty impressive. Looks like where the VEGF was delivered, significant increase in angiogenesis and vascularization. But then, as I mentioned, and go back to that pharmacokinetic study that I showed you early on, interesting thing happened. We were going but direct myocardial injection. Again, this is what our data showed us. We found that we and others who had used direct myocardial injection found that there appeared to be a significant improvement in terms of exercise treadmill based upon EKG. But then there were a number of trials. The VIVA trial, again, this was a Genentech trial. Napoleon Ferrara, brilliant scientist. Chiron did a study with basic FGF. And in these placebo-controlled trials, again, these were intracoronary, so they could use a placebo. No significant improvement in terms of exercise treadmill. Everyone said, you see, those scientists, those guys at Cornell were wrong. This was all placebo effect because it was direct myocardial administration. Everyone wanted to feel better. But when you did the good placebo-controlled intracoronary trials, no effect, and therefore placebo-controlled trials are always better than open label, and therefore field doesn't work. We, of course, argued that there was a 100-fold decreased uptake in the myocardium with intracoronary, fell on deaf ears. This was all sort of written off as a placebo effect. And then a very significant thing happened. Again, let me go back to an anecdote, and admittedly this is an anecdote. Our most famous patient was columnist for Time magazine, Lance Morrow, who had done a story about gene therapy. Again, this is in the late 1990s. And then came back a few weeks later and said, you know, I did the story, but I'm actually need to be in your trial. I've had a couple of heart attacks. I can barely get across the room anymore. And he subsequently wrote a trial about going back and playing squash and doing great. And in fact, we stay in touch to him to this day, 10 or 15 years later, and continues to do well, interestingly. So again, looking pretty good. Gene therapy seems to be working. And then a tremendously tragic event happened. Again, probably everyone in this room will recall back in the late 1990s, a young man named Jesse Gelsinger got about a 1,000-fold excess dose of an adenovirus. He was being treated for a benign inborn error metabolism of ornithine transcarboxylase. Was not affecting him at the time, and he died from inflammatory effects of a 1,000-fold excess dose of adenovirus delivered intravenously. And basically this put a hold on all gene therapy studies in the United States, an FDA moratorium, and it literally took about 10 or 15 years for the field to recover. Again, very famous scientist, Jim Wilson and his team at Penn had been doing great work in the field, and clearly made an error in terms of administration. So then an interesting thing happened. We, as many others, walked away from the field. Joe Wu, surgeon, had been involved as well, and we all really went on to other things, stem cells in particular. I, at the time, had left Cornell, gone out to Northwestern, and then came back to New York about 10 years later. An interesting thing started happening. One after another, a number of these patients who had been in the original gene therapy trial started calling. Say, hey, Dr. Rosengart, I hear you're back in town. Just wanted to let you know I'm feeling pretty good. I don't have any more angina, and glad you're back in New York. Great, that's really nice. Second time happened, third time happened. About the fourth time one of these patients called, I said to myself and sort of almost said out loud, you know, I thought you'd be dead by now. It's, you know, 15 years later, and you had end-stage coronary disease, and you're telling me you're angina-free. You know, fortuitousness is only useful unless you do something about it. And in speaking to Ron Crystal, he said, we really need to follow up on this. We tracked down all of our patients, about 32 who had received VEGF in our trial. And interestingly, just as a data point, what we found is that the survival of these patients compared to a TMR control group, again, TMR again, was, again, no statistics here, but seemed to be better. Certainly 10-year median survival, much better than we would have thought in this end-stage coronary disease patient. And perhaps more interestingly, and again, think back to the angiogram of the pig. Here's an angiogram 10 years after VEGF therapy in one of the patients, and we had about 3 or 4 patients with similar angiograms. And you can see that, again, that plexus of blood vessels, this was exactly where it given our VEGF therapy, persistent 10 or 15 years later. So we got to thinking about it, and we decided maybe we need to go back and pick up the work where we left off. Isn't it the right thing to do? And classic sort of Silicon Valley story. I was telling the story to a friend, actually a gentleman owns Hudson News, if you're in the airport. And he said, you know, this is, you really should be ashamed of yourself, Todd. You really should continue this work. And I said, oh, you don't understand. It's complicated. And he persisted and persisted, gave us some seed funding, and we went back to the laboratory and said, if we had to do it over again, how would we do it differently and better? And so one of the parts of the VEGF story, again, as everyone knows, is that VEGF doesn't come just as a single polypeptide. It actually undergoes post-transcriptional splicing and ends up as three different major isoforms, 121, 165, 189. Again, as anyone in the field knows, they have different biological functions. They do things slightly differently in terms of relevant receptors, heparin binding, and the like. And we said, well, you know, if Mother Nature has three isoforms, maybe just delivering one isoform like 121 or 165, how the trials were done, is not the most effective way. And Ron Crystal and his team, who are really truly experts and quite innovative, created this genomic VEGF, which we called VEGF-all, that actually expressed all three isoforms. So seen here on this Western over here, and, all three, about 2 to 1, 121, 165, 189. Went back to the laboratory, looked at a hind limb ischemia model, and what we found basically is that the VEGF-all was approximately 100-fold more potent than VEGF-121, which was encouraging in terms of a new clinical trial. In fact, Ron went one step further, looked at alterations of the proportions of 121, 165, 189, and we created a VEGF-all 6A+. This has to do with the expression of the 6A exon. And what he found, long story short, is that VEGF 6A+ is just as potent as VEGF-all, but when you look at things like pulmonary edema and even toxicity and mortality, VEGF 6A+ was safer, likely because there was less VEGF 121, even though we had no trouble in our clinical trials, but because of its ability to induce vascular permeability and the like. So we went back to the FDA. We still had the TMR tape in our back pocket, but at this point, interestingly, when we went to FDA, they had no concerns about safety, which is very, very significant considering how far the gene therapy field had come. But what we proposed to them and received approval from the NIH Recombinant Advisory Committee is we said, look, the biggest problem with the VEGF trials back in the 90s was that the ones that worked, such as ours, we argued, didn't have a placebo control. And so NIH and FDA said, well, not only do we think having a placebo-controlled VEGF trial is an interesting idea, we actually think it's the most ethical thing to do. And the NIH Recombinant Advisory Committee, is depicted here, actually approved a clinical trial where we would randomize patients 3 to 1 with end-stage coronary disease, either get VEGF-all or actually get an null vector that might have some inflammatory effects, but it clearly was in negative control. And then NIH approved that unanimously, 18-0. And FDA, although they want us to stop at Part A, which is the open label trial, will hopefully be supportive as well. And we're about ready to undergo that trial, which will look again at the primary endpoint at time to 1 millimeter ST depression, other standard secondary endpoints. Interestingly, we're going to include cardiac PET, which we think will be more sensitive. And we'll be conducting this study in New York at Cornell with Ron Crystal and his group, and at the Texas Medical Center, which everything's bigger in Texas, so it's the world's largest medical center, and obviously hopefully a very suitable place to recruit patients. So that's where that story leaves off. And now let me go back to a little bit of sort of unthinkable science. So I think part one is the unthinkable part of what you can do with some persistence and belief in the basics of the science. Let me go back and talk again about what I think from a scientific standpoint, as many in this room know and have been working on, is something even more unthinkable, which is taking one cell type by direct reprogramming and converting it into another. Obviously, this field all came about because of Yamanaka's work with the IPS generation, as depicted in the box. But the problem, as I alluded to earlier, is that with all stem cells exogenously delivered, the problem is how to get past integration into the host genome, host milieu, the host myocardial matrix, in a way that's clinically relevant. So Deepak Srivastava, just up the road at UCSF, really was the pioneer amongst others, Eric Olson, in taking Yamanaka's work and taking it one step further. And basically he said, well, if you can take an adult somatic somatic cell, use OXOX-KLF4 to induce iPS cells, perhaps you could take another combination of transcription factors and directly reprogram without going through an iPS stage from one adult somatic cell type into another. And what Srivastava showed in his work that came out about now, I think, 4 years ago, was that you could take a GATA-form, MEF2X, and TBX5, MEF2C, and TBX5, which are associated with cardiac differentiation in the embryologic state, using a lentivirus, and directly transdifferentiate fibroblasts into induced cardiomyocytes. And Srivastava, in a very elegant paper, seemed to demonstrate this. We, quite frankly, couldn't believe it, never having been taught anything like this was possible. And we repeated Srivastava's studies and, in fact, duplicated what he saw. So as depicted here, if you start with cardiac fibroblasts in vitro, administer GMT, you could actually upregulate cardiac-specific markers, in this case looking at cardiac troponin T. In GMT-treated fibroblasts versus control fibroblasts, we can see marked and dramatic staining for cardiac troponin T. If you look at other markers, such as myosin heavy chain 7 or alpha-sarcomeric actin, similarly upregulation of these markers. And in fact, Srivastava and others went on to show that in vitro you could actually induce contractile cells. So this creates a to me as a cardiac surgeon in my day job, an intriguing possibility, which is instead of administering exogenous stem cells and trying to get them integrate into the host myocardium, perhaps you could again take these transcription factors, just an aliquot of solution, inject it into a large area of scar and actually transdifferentiate scar fibroblasts in situ, so they're already integrated into the host myocardial architecture, to induce cardiomyocytes and therefore regenerate myocardium from areas of scar tissue. So again, very, very important to think about the basics. And one of the first questions we asked, which sort of befuddled us and really hard to believe, we thought we were missing something, is the I don't understand question. And again, so if thinking of this as a cross-section of heart, infarcted myocardium here, why did the heart become fibrotic? It was because there was an inadequate blood supply. All of those resident cardiomyocytes died, became replaced by fibroblasts. So why, if there's still ischemia, if we injected cells into the scar tissue, would you get anything other than persistent scar? And the injected cells undergo the same fate as the resident cells, which would be to undergo apoptosis or otherwise die. And in fact, work by Murray and McGovern showed exactly that. If you inject exogenous cells, about 98% of them are dead within a couple of days, either because of poor delivery or, again, ischemic loss. So we did a series of experiments. This, again, is about 5 or 10 years ago. We were still, at this time, looking at stem cell delivery. And we said, okay, well, since we're angiogenic people, everything, if you have a hammer, everything looks like a nail. Why don't we create a scar? Let's pre-vascularize the scar with VEGF. So we're essentially fertilizing the soil before we deliver our cells. And we speculate that if you pre-vascularize, provide a blood supply to that scar tissue, then inject those cells, you'll have a better result than if you just try to get those cells to stay alive in this hostile ischemic milieu. And we did some experiments early on, and we treated animals with VEGF and nothing, cells and nothing, or a combination of pre-vascularization. We actually put the rats on a treadmill. This is clearly not a Stanford student in the front. And what we showed is that with the prevascularization, we could significantly enhance exercise treadmill results, and that became our standard model of prevascularization. So I'll come back to that in terms of further studies. So if we're going to do in situ cellular reprogramming, again, the same model. Induce infarction by coronary ligation, prevascularize, wait 3 weeks, which is how long we knew it took for the new blood vessels to grow, and then either administer GMT, GATA-form F2C, TBX5, or a control vector, and then wait 4 weeks and look at results. And much as Srivastava and others showed, quite dramatically and a tremendous surprise to us. If you look at histology, this is control, bland infarction. Coincidentally or not, and the data is the data. In the treated animals, we see these persistent islands and strands of myosin heavy chain positive staining cardiac myocytes, be it induced cardiomyocytes or native. We couldn't tell for sure. Looking at trichrome staining for fibrosis control, not only is it tremendous thinning, you actually have aneurysm formation compared to an almost normal looking cross-section of treated myocardium, and then as shown looking at ejection fraction by echocardiography, again what appeared to be dramatic improvement in function. Again, looking at it statistically, looking at myocyte density, statistically significant improvement in induced cardiomyocytes, statistically significant improvement in the amount of fibrosis, and finally looking at ejection fraction, VEGF pretreatment plus GMT, statistically significant improvement in ejection fraction at dramatic 20-30% levels with this reprogramming versus control treated rats. Interestingly, if we were using 3 vectors, and this is sort of confirmation of what we had done previously, the GMT were all being administered with 3 separate lentivirus vectors. If we combine those into a single triplet vector, so each cell is not needing to be exposed to 3 different transgenes, but all in one vector at the same time, we showed a significant improvement in function. At this point, it was up to a 40% improvement in ejection fraction using this triplet vector. Again, very, very encouraging data suggesting that you could actually reprogram hearts by this technique. Most recently, this is a material that we'll hopefully be presenting this year. Going back to what we had originally talked about, all of this work involved lentivirus or retrovirus chronic expression vectors, but most recently we've now reduplicated these efforts and show that we can actually use an acute expression adenovirus vector to also induce improvement in heart function. So perhaps most dramatically, Olson and others have most recently shown that even though we're getting these very, very encouraging results in lower order animals such as mouse and rats, when you get to higher order animals such as humans, all of the data suggests that our cells are much more resistant to reprogramming, probably because of epigenetic stabilization. Compared to lower order animals, and in fact adding GMT to human cells in particular would not induce reprogramming, and Olson and others have now shown that only by adding multiple other factors such as HAN2, myocardium on top of the GMT could you induce the reprogramming of cells such as human cells. So obviously to study these things we needed a good surrogate, and most recently, and I don't know if this will play, but we've actually now been able to go to in vitro pig cells, and as you can see here, we've been able to induce beating pig induced cardiomyocytes. These were originally fibroblasts that are now beating based upon administration of reprogramming transcription factors. So our most latest work, and the theme of this could potentially be, we could be tadpoles if you'd like, is how do we get past this problem of antiplasticity of human cells versus rodent cells. And probably, and this is an area of a new investigation, there's a lot going on in human cells that's not present in rodent cells that are preventing our genes from being activated. And 2 factors that are probably very significant in this that we found out through IPS studies is P53 and P63. So obviously everyone knows that p53 mutations are one of the primary causes of oncogenicity, but we actually believe we have found that we could actually turn that around and look at it from a therapeutic standpoint, and not focusing so much on p53, but its cousin in the p53 family, p63. As much as when these are downregulated, they promote mutations and oncogenicity, essentially by allowing increased cell plasticity. We could take that to our advantage in terms of reprogramming, and we most recently have shown that if we downregulate p63, this anti-plasticity gene, we could significantly increase, as shown down here, our ability to reprogram fibroblasts into cardiomyocytes, as evidenced by nearly a 7-fold increase in CT expression in these cells. So very early work, very exciting, essentially suggests that there are a lot of ways to enhance the plasticity of mature somatic cells, such as fibroblasts, for the purposes of reprogramming, as suggested by these data. So in conclusion, really, on what has been an incredible, hard to believe 30-year journey, I think we are back in the gene therapy arena. We will be seeing more and more in terms of clinical applications, including angiogenic gene therapy trial that we look forward to beginning this year. We think that going back to the basics and the concept of pre-treating the infarcted myocardium is incredibly important in terms of making sure you have essentially all of the principles aligned in terms of ideal opportunities for enhancing these therapies. And finally, although formidable barriers remain and work at places like Stanford and others will inevitably and undoubtedly lead to advances in the field, we think that there's an entirely new chapter to be written in the next 5 to 10 years in terms of using cardiac cellular reprogramming to completely rewrite how we treat patients with advanced heart disease. So again, regenerative therapy is truly a new paradigm for treatment of heart disease. We think it is something that we'll be seeing increasingly greatly. And I thank you for your time and attention. Thank you.
Todd, thank you very much for that amazing lecture, showing us both some history and really what the future is going to be. I think we have just a couple moments for a few questions from the audience. Phil Yang.
Thank you. That was a wonderful talk. And I'm very impressed with all the images that I saw. But one that kind of stuck in my mind is that fibrosis slide that you showed, and the complete regeneration of that fibrotic lesion. Number one, what's the potential mechanism? Meaning, did all the cells actually become cardiomyocytes? And if so, what's the efficiency? And secondly, what's the functional improvement that you saw after that treatment?
Yeah. So as we were talking, or thanks, Phil, as we were talking earlier, I think what's most interesting for this, so this is kind of the data you see from your own laboratory, and you say, well, what did we do wrong? You can't really believe it. And one thing that's heartening, so to speak, in that is there's now about 4 or 5 groups, Olson, Srivastava, some of Deepak's disciples have now gone back to Japan. We're all seeing the same thing. So the fun part is I think we've got the end point, which is there truly is 20 or 30% statistically significant improvement in function, which of course is the clinically relevant endpoint. We actually now need to take a step back and really, really understand what's happening. And I think it would be foolhardy for us to say we're creating these cells and that's the story. There are clearly other things going on. For example, there's probably an anti-fibrotic effect. It's potentially GATA4 playing a role in that. There's probably other things going on. And we just don't understand. And for anyone in this room who's looking for something to study, I think especially because we know that we don't know, but we seem to have evidence that it works, it's just a fertile opportunity to go back and start understanding mechanisms. That's obviously what we're spending a lot of time doing. The efficiency, the other thing I would say that, again, is fascinating in this field is it appears, and again, we're talking about this morning, that the efficiency in vivo, sort of fortuitously, is actually better than the efficiency in vitro. And we see that a little bit. One of the magic tricks that I didn't fully explain was that on those beating pig cells, they only work if you have co-culture with cardiomyocytes. So and again, we feel comfortable that these truly are the pig fibroblasts, but yet you need the co-culture, and again, DeBakey has shown that too. So there's clearly in vivo, in situ, crosstalk, communication, hand waving, we don't understand it, that is important to making this more successful, more efficient in vivo than in vitro. So wide open opportunity to try to figure this out.
Sean.
Yeah, nice. Beautiful talk. It's a real good, of course, with a 30-year history of research progress that you're making.
Thank you.
I'm curious about, as you go back into the VEGF studies again, are you still using adnos, or you're converting to AAVs, or what's the
Yeah.
future?
So, and again, I was talking to Joe Wu about this earlier. We believe in adeno. And one of our greatest frustration, we believe in it not just intellectually or emotionally, because we've used it clinically, we've intensely looked at safety parameters, we've never had safety parameters issues. We know that it works for as long as we need it to. We don't want to have chronic expression with AAV. And one of the challenges, again, it's one of the sort of the fascinating things about how the field works is that the science and the sort of feeling on the street just don't line up. And one of our challenges, all of us, and again, Stanford, of course, is one of the great incubators of translational science, is to convince and explain to the lay public why their impressions are not scientifically based. And much more than the science, communicating properly communicating people away from false impressions that adeno is bad are one of the greatest challenges we face, much more so than just the science. So yeah, we are using adeno. We think it's the perfect vector for this utilization. And interestingly, when we went to FDA and NIH and said we want to use adeno, there's no issue. They're completely supportive. They're actually not even asking us to do all the safety studies that we did in our original phase 1 studies. And again, for those who actually...
They knew you had the tape.
They knew we had the tape, right. Very interesting paradox that goes beyond what you do in the laboratory.
So one last question. Whenever gene therapy comes up, I always ask what the status of, for cardiac gene therapy, what the status or theoretical potential of Coxsackie virus would be as a vector.
You stumped me. Can't answer.
Yeah. Okay. Good.
Are you going to tell me?
No, I don't know. I think of the natural disease process and the relationship of Coxsackie to myocarditis. I mean, it's a vector that's in nature designed to get into cardiomyocytes,
Yeah.
and no one has really harnessed it, and it's just something that maybe is too dangerous to look at. But anyway, thank you very much for that wonderful talk, and I would invite everyone to join us in the photo.
Stanford University.